us start with the mandible first. Let me make you understand few important features of the mandible. When you read osteology from the textbook of like BDC and Vishram, बहुत बड़ा लगता है. When you see osteology is huge. They've written so many things about it because they have to. It's a textbook. So they will be writing about, okay, there is a ramus, it is having an anterior border, it is having posterior border, upper border is notched. But when you start explaining these things, it will take hardly 10, 15, 20 minutes only. In the mandible, what you see in here, guys, this here obviously is the head of mandible. You know, this everything will be used when I talk about the muscle of mastication. This is the head of mandible. This here is the neck, just below the head, that is the neck of the mandible. And you already remember the neck was where the medial to the neck was the first part of maxillary artery. There is a neck here. And on the anterior surface of neck, if you see, on the anterior surface of neck, there is a fossa over. There is a very small depression which is present on the anterior surface. But I'll try to label it neatly so that I can share these images with you directly without labeling them again. This here is called as the pterygoid fovea. Guys, fovea means a small fossa. A fossa, and the smaller fossa is called as fovea. So anterior surface of neck of mandible is having a depression which is called the pterygoid fovea. This process here is called as the coronoid process. This process here is called as the coronoid process. And the notch that you see, let me label that notch here. This notch that you see between the coronoid process and the head of mandible, this is called as the mandibular notch. This is called as the mandibular notch. You will understand the reason why we have this mandibular notch, because it is providing the passage for some nerves and blood vessels to come out. Like masseter muscle will be present outside, we will discuss that. So what you will see that mesenteric nerve and mesenteric artery will be coming out of this. Mesenteric muscle is outside the ramus of mandible to supply it. The nerve to mesenteric and the artery to mesenteric will use this mesenteric notch to come out. So that's why we have this mesenteric. This whole part here is called as the, below this coronoid process, like this whole thing is the ramus of mandible. This here is the ramus of mandible. And of course, this in here is the body. That's the body, and I'm sure you all know that is the angle of mandible. Ramus, body, and the angle. If you look at the medial surface of the ramus, if the lateral surface, if you look at the medial surface of ramus of mandible, you already know about this foramen here, that is called as the mandibular foramen. That foramen is mandibular foramen. And guys, this mandibular foramen is running as a mandibular canal inside. Obviously, we can't see that. It is running as a mandibular canal, one on this side here, and will be emerging out as what foramen? That is the mental foramen. This is mental foramen. We have a mental protuberance also in front, that is mental tubercle or mental protuberance are there. We saw in the norma frontalis, we have this mental protuberance here, and the symphysis mentae. Junction of both sides of this body of mandible is called as the symphysis mentae. Symphysis mentae. Now, one very important thing to note here is inside. Can you see a line over there, guys? On the body, if you see on the medial side of the body, there is a line over there, and that line is called as the mylohyoid line. That is a mylohyoid line. Clearly, it is the origin of the mylohyoid muscle. So that is where the mylohyoid muscle will originate, and then it will go downward toward the hyoid bone, and has a median raphe also. It is having a median raphe also, where both side mylohyoid will meet. So the origin of mylohyoid is on that line. That is the mylohyoid. When you think of muscle of mastication, which I'm not drawing as of now, I'll draw it separately. When you look at the muscles of mastication on the mandible, obviously I will represent them with a blue color, because muscles of mastication will be inserting here. Whether it is temporalis, medial pterygoid, masseter, or lateral pterygoid, obviously they have to move the mandible. And if the mandible is a movable bone, so obviously you will only see the insertion of temporalis, masseter, medial, lateral pterygoid. I will be discussing all these muscles in detail with you, because if you know their precise attachment, and if you also understand what is the direction of the muscle fiber, you don't have to think too much about their action. You will understand their action automatically if you just understand the direction and the detail attachment. And detail, because they are a question also, they are like short note questions for you, and it's a long question as well, the TMJ and muscle of mastication. Okay, let me show you one more picture of the inside of the mandible, guys. Just a couple of things to note here. Now this time you're looking at the mandible from the inside, right? Now can you see some tubercles over there? Now those tubercles that you're looking at, those tubercles are called as genial tubercles. We have two genial tubercles. So basically there are four genial tubercles. We have two superior genial tubercles. Genial is like gem-like. We have genial tubercles, and we have two inferior genial tubercles. So we have two each. That's usually, sometimes they look fused, but yeah, there are two superior and the two inferior genial tubercle. Now think about it, guys. Superior genial tubercle, if a muscle will start from the superior genial tubercle, that muscle will go up, and the muscle which will originate from the inferior genial tubercle, that will go down. So the muscle starting from the, or muscle originating from the superior genial tubercle, that muscle will be called as what? Genio. And going to the tongue, it has to go above, upper tongue, so muscle is what? Genioglossus. Superior genial tubercle will give origin to the muscle genioglossus, whereas inferior genial tubercle will give origin to the muscle that is geniohyoid. Each are to the hyoid bone, so that muscle will be geniohyoid. Genioglossus and geniohyoid, right? Geniotubercle. So that is where they are starting. That's where they are starting. And when you look at the lower border of this body of mandible, in the anterior part, we have two depressions also. One on this side, one on this side. Not to be seen very clearly in this picture, but let me tell you. Those are called as the digastric fossa. So we have two depression here, and the lower border of the body of mandible, close to anterior side here, where you can see my two thumbs here, that is called as the digastric fossa. Obviously, why do we call it digastric fossa? Which muscle? Anterior belly of digastric will be attached here. So this is where you have the attachment of anterior belly of digastric. I still haven't told you about any muscle of mastication, because that we are going to discuss separately. So apart from muscle of mastication, the important muscle I'm saying is muscle तो और भी है like mentalis and all these muscles are attached here. But the important muscle that you should remember here is digastric attachment, digastric fossa, anterior belly digastric, geniohyoid, genioglossus, mylohyoid. These are the important muscles to be remembered apart from muscles of mastication. Now let me take you to the muscles of mastication itself. I'll be sharing these pictures with you. Today I'm going to label all these nice and slow and easy so that I don't have to label them again and then send you उसमें कई बार time ज़्यादा लग जाता है. Now guys, okay, this picture here is showing like red is obviously for the origin and the blue is for the insertion. So many muscles are shown in here. Our focus is only to the muscle of mastication. So we'll be taking all these 4 muscles in detail one by one, starting with temporalis muscle. Now, if you look at this picture first, guys, temporalis muscle, this entire thing is the origin of temporalis muscle. What is that fossa? That is temporal fossa. Now, when I say temporal fossa, that doesn't mean only the temporal bone. I told you this earlier also. Temporal fossa, we have a temporal bone also. We have a parietal bone also. We have a frontal bone also. We have a sphenoid bone also. You can see all the sutures which are meeting here. So that's the entire fossa is called the temporal fossa. You know, there was a line called the superior temporal line. When we were discussing the scalp, we said we have a line called the temporal line. So everything below that is the entire fossa, is the temporal fossa. So temporal is the largest muscle of mastication. It is originating from this entire temporal fossa and also from the temporal fascia which is covering it. So there is a fascia outside it, that is temporal fascia. So the muscle is taking origin from inside also from the bone and outside also from the fascia. So दोनों के बीच में. So this is the muscle here temporalis for me. So it is basically taking origin from the temporal fossa and from the temporal fascia also. And then what this muscle will do, it will go down like this. And obviously what is that zygomatic arch? So it will pass deep to, or you can say medial to the zygomatic arch, it will come down. And what process there guys? We already discussed that. That is the coronoid process. It will insert to the tip of the coronoid process, to the medial surface of coronoid process, and if you look carefully, also to the anterior border. Can you see that? Can you see the blue color shown on the anterior border of the ramus of mandible also? So that is the entire insertion of the temporalis muscle. I'm showing you, then I can make it right also guys. Origin, simply temporal fossa, whole of the temporal fossa and temporal fascia passes deep to zygomatic arch, inserted where? Tip of the coronoid process. Medial surface on the other side, on the medial surface of this coronoid process, and also it is extending along the anterior border of ramus of mandible. Anterior border of ramus of mandible. How about if I show you a picture of the temporalis muscle? Look at that. Look at this muscle guys, right now you can see we have this whole muscle here which is converging downward, going deep to the zygomatic arch, and then you can see it is inserted to the coronoid process, and if you look carefully, it is also extending to the anterior border. If you look at this is extension to the anterior border of ramus of mandible, right? And also to be noted, when you look at temporalis muscle, we have 3 type of fibers. We have these fibers which are running vertically downward. Can you see that? We have fibers which are running down vertically downward. Then we have fibers which are running obliquely downward, and then we have fibers which are almost horizontally placed. And why you should know about the direction of the fiber, because that will help you decide what will be the action of this muscle. But temporalis muscle mein, we have fibers which are running like this. That is the fiber running downward. These fibers are running obliquely downward, and these fibers are almost running horizontally. Whatever the direction of muscle fiber is, and this is for everywhere. This is applicable everywhere. Whatever the direction of the muscle fiber is, exactly opposite will be the action. If a muscle fiber is going downward, obviously it will pull the bone upward. If a muscle fiber is going forward, it will pull the bone backward. So it is attached to coronoid process. So what will it do guys? These 2 fibers, the one which is vertical and oblique, when these fibers contract, obviously they will pull the mandible above. Pulling the mandible above means what? Closing of mouth. That is elevation of mandible. Closing of mouth or elevation of mandible is done by this. But the posterior fiber, the one which are horizontally placed fiber, they are running like this. So when these fibers will contract, they will pull the mandible backward. Pulling the mandible backward means retraction. Well, you cannot retract from the normal position. Right now my jaw is normal. So इससे पीछे कहाँ जाऊँगा? I cannot go. But if you protrude the mandible like this, if you protrude your jaw forward, then it is bring back to its position by which muscle? Temporalis muscle. Which fiber of temporalis? Posterior fiber. Why? Because they are horizontally oriented, so they can pull the mandible backward, and that's why they are responsible for retraction. So the 2 main action of temporalis muscle is what? Elevation of mandible, that is closing of mouth, and retraction of the mandible. बिल्कुल नहीं रखना है. Just think about the muscle, try to understand what is the direction of the fiber, and then see that why the action is such for this muscle. I want each and every one of you, although all these attachments are given in the book, but please do write it down because they are very, very frequently asked in the exam. So the first muscle guys we're talking about is temporalis. So it's a large fan-shaped muscle. You can already see that it's a large fan-shaped muscle. Origin. What was the origin of the muscle guys? Where was it originating? It was originating from the entire temporal fossa and temporal fascia also. The fascia which will be covering the muscle is also giving its origin. Temporal fossa and the temporal fascia. Temporal fossa and temporal fascia both are the origin of this muscle. That's a special point you can add in the muscle of mastication, that what is the direction. Before I write the insertion, what is the direction? So we have the anterior fibers, but the anterior fibers, they run vertically. How? Vertically downward. That's what we said. They are running vertically downward. Middle fibers, they are running obliquely downward. They are running obliquely downward. And posterior fibers are running horizontally forwards. Downwards me, but horizontally forwards. That's the important point. It is running horizontally forwards. That's what we saw. The direction of this muscle, that's how it was. Insertion. we will not be discussing all the muscles of the entire body like this in this detail, but this is needed. This is definitely needed. Insertion, guys. What is the insertion of this muscle? The inserting point is it is inserted to the tip and medial surface of what? Of the coronoid process. Tip and medial surface of coronoid process, and also it is also inserted along the anterior border of ramus of mandible. Anterior border of ramus of mandible. You got to see these pictures, otherwise you will forget about these attachments, the detailed attachment. Because if it is a question, you have to write it in detail. Tip and the medial surface of coronoid process and anterior border of ramus of mandible. So that's the origin, the direction, and the insertion. That's the insertion. Okay. Nerve supply. Before I go to the action, nerve supply. Well, we all know that deep temporal nerves. Deep temporal nerves, which are coming from the anterior division of mandibular nerve. Now, this is your job to think where it was. We've already discussed mandibular nerve. We saw trunk is supplying the medial pterygoid, and rest of the muscle of mastication are by the anterior division. So, deep temporal nerves, there are usually two, and that is coming from the anterior division of the mandibular nerve. And the important thing is the action. Now, what's the action of the muscle? The action of the muscle is based on the direction of the muscle fiber. So, because anterior fibers are running vertically downward, so this definitely helps in the elevation of mandible. Elevation of mandible. And guys, when I say elevation of mandible, I'm talking about the closing of mouth. That's one action. And the second action is because posterior fibers are running horizontally forward, so they will retract. But the important point, they will retract the protruded mandible. The mandible which is already protruded, आप उसको तो retract करोगे ना, the one which is in normal position, what will retract in it? It is already normal. So when the mandible is protruded, the retraction is done by the temporalis muscle, the posterior fiber of the temporalis, which are running horizontally forwards. So this is about the temporalis muscle, right? This is all, if possible, just draw a rough diagram here, but you have to write about the origin, insertion, tell about the direction of the muscle fiber, nerve supply, and the action of the muscle. Okay. Let me take you to the next muscle, guys. Let me take you to the next muscle, and that next muscle here is the masseter, the strongest muscle of mastication. Temporalis was the biggest, it's the largest muscle. When I come to masseter, it is the strongest muscle of mastication. How about if you look at the attachment once again on that schematic picture? Okay. Masseter muscle, if you see, the origin of the masseter muscle is indicated by this red line which you see on the zygomatic arch. I hope you all can see that. And beta insertion is shown by this blue color present on the outer surface of the ramus of mandible. Masseter muscle, basically it is having three bands, or you can say the three lamina or the three fibers we have masseter muscle. We have more superficial layer of masseter, we have middle layer of masseter, and then we have deep layer of masseter. So this muscle is such a thick muscle. When you clench your teeth, just tighten up your teeth like this. Clench your teeth and you can feel the muscle on the side. This muscle is masseter here. So this is such a thick muscle, it's a very strongest muscle of mastication, and it is arranged in three layers. So we have a superficial layer, we have a middle layer, and we have the deep layer. Although it's very easy to understand that where they are originating from, I'm going to draw it for you guys. But a superficial layer, the most superficial layer will originate from the anterior two-third of this zygomatic bone and zygomatic arch. Anterior two-third, it is originating from the lower border of, obviously, from the lower border of anterior two-third of zygomatic arch. Anterior two-third of zygomatic arch. Middle fiber are originating from the lower border of posterior one-third of zygomatic arch. And deep fiber, abhi khud hi socho aap. If entire this border is utilized by the what fiber, superficial fiber and middle fiber, then obviously deep fiber will be coming from somewhere inside. Now when I say somewhere inside is what? That is the medial surface of zygomatic arch. Medial surface of zygomatic arch. Lower border is giving origin to the superficial fiber and the middle fiber. The deep fiber will be coming from the medial surface of the zygomatic arch, the one which is inside. And then the entire muscle will converge downward, obviously, and will attach to the outer surface of the ramus of mandible. Many books have explained that which fiber are going where, like the most superficial fiber are coming more inferiorly till here. These fibers will come till the middle part here, and the deeper fiber will come till the upper part here. But ultimately, they are all inserted onto the lateral surface of ramus of mandible. Right? This is about the masseter muscle. I want you people to not only write about it, we'll have a schematic line diagram also so that you remember this attachment. Just let me quickly show you the muscle also better. Look at this muscle. In this picture, you can see the superficial fiber, and you can also see the middle fiber. Look at this. This whole thing here is the superficial fiber here. And look at this. This here is the middle fiber shown. Deep fiber obviously are more deeply placed inside. That's not shown. They're not shown. So, talking about this, the second muscle in the line, that is masseter. This muscle beta is a quadrangular muscle. It's a quadrilateral shaped muscle actually. That was fan shaped muscle, and this one is a quadrilateral. It's a quadrilateral shaped muscle which is covering the ramus of mandible, and temporomandibular joint also is covered by it. Origin. Now, as we said, the origin depends upon which fibers are you talking about. So we have a fiber that is a superficial fibers or superficial layer. Then we have middle layer, and then we have deep layer or deeper layer. 3 layers, right? Can you help me? Help me out, guys. Where was the superficial layer? I'm going to draw it for you also schematically. Superficial layer was originating from the anterior two-third of lower border of zygomatic arch. Anterior two-third of lower border of zygomatic arch. Middle fiber is from the posterior one-third of lower border of the zygomatic arch. Same story, but that's from posterior. And deep fiber, obviously, entire lower border is now occupied. So what is the next thing? The medial surface. So deep fibers are originating from the medial surface or deep surface of zygomatic arch. Medial surface of zygomatic arch. So think about zygomatic arch only, although it is having attachment to zygomatic bone also, but zygomatic bone itself is contributing to zygomatic arch. So you better stick to zygomatic arch only. Superficial fiber, middle fiber, or under side from the medial surface, they are the deep fiber or the deep layer of this muscle. Deep layer of this muscle. This muscle is running downward. This muscle is running downward and it is running slightly backward also. If you just go back to the picture, you see the muscle is running downward and slightly backward also. Again, to understand the action of this muscle, we have to understand the direction. So the direction of this muscle fiber is, it is running downwards. Of course, they all have to go toward the mandible, so it is running downwards and backwards. Downwards and slightly backwards. Insertion, guys. Insertion, what is the insertion? It is inserted on the outer surface of ramus of mandible. Don't write about, even if it's a short note question, you don't have to write about the superficial fiber will come below, middle fiber will go here, and the deep fiber will be above. Doesn't matter. It's simply the outer surface of ramus of mandible. That is where it is inserted. Nerve supply, same story. Mesenteric nerve. You know it. Nerve to masseter or mesenteric nerve, and this mesenteric nerve is also coming from the anterior division of mandibular nerve. Anterior division of mandibular nerve. And finally, action. Now, before we talk about the action, guys, let's have a very quickly draw this thing. Now, we said this whole thing is the zygomatic arch, and then we have a mandibular fossa, which we will be discussing next here, behind the external auditory canal and all that. So, this is zygomatic arch basically. Here we have head of mandible, neck of mandible, and that is the ramus. Conoid process, we don't have to draw the entire thing. Let's say this is. So, we said the origin is from here, from the lower border. Superficial fiber will be coming from here. Middle fibers will be coming from here. And the deep fibers, I can't see them because they are coming from the deeper aspect, from medial aspect. And the muscle, because we said it is attached to the lateral surface of ramus of mandible, so muscle obviously is running like this. So when you see this muscle inserted, the muscle is inserted like this. To me, the important thing always is the direction. Downward and backward. Niche bhi aa raha hai, going backward also. If a muscle fiber is going downward and backward, obviously when this muscle will contract, it will pull the mandible upward, of course, and forward, exactly in the opposite direction. The muscle fiber is downward and backward, so it will take the mandible forward, and it will also take the mandible upward. So that's why, based on the direction, I can say the action of this muscle will be, once again, the elevation of mandible. There is elevation of mandible, you know what is that? And what? This is pulling the mandible forward, so that is protraction. Although it is not the main muscle for protraction, but the direction is telling you it will also help in the protraction here. Right, guys? That is also going to help you in the protraction. Elevation of mandible and protraction. You remember the direction of muscle fiber, and that is the best way to remember the action. Otherwise, later on you will forget it, and they mix and match question in such a way that you probably have to choose muscles. Like they may not ask you muscle and tell the action. They may ask you action and will ask you which all muscles will do it. Like elevation is done by which all muscle. So that times become a bit confusing if you don't know the direction. Remember the direction of muscle? It's very simple. How about we just again very quickly look at the same picture just to show you this mesenteric muscle. Look at the direction. The direction of the muscle is like this. So obviously when this muscle contracts, it will pull the mandible upward towards the zygomatic arch, and it will also pull the mandible slightly forward, and that's why it is elevation and protraction is the action. Coming to two pterygoids here, the lateral pterygoid and medial pterygoid. This is where the maximum people get stuck understanding the pterygoid. I will explain you both the pterygoid together and then write about it, guys. Why pterygoid muscles are so important? I mean, why pterygoid muscles orientation is so important? Because these muscles are responsible, apart from other action, elevation, depression to head. The special action of these muscles is this: sideways movement. You can move your jaw side to side, and that is done by the medial pterygoid and lateral pterygoid. But how can a muscle on one side can produce a deviation of the jaw to one side to the other side here? That can be understood by again looking at the direction of the muscle fiber. Okay. This picture has already helped us, a lot in understanding the maxillary artery and other things. This again is going to help you guys. Imagine this bone here. Well, we all know that is a part of a sphenoid bone, and that plate is what plate? That is the pterygoid plate. Which pterygoid plate? That's a lateral pterygoid plate. If I remove this lateral pterygoid plate, this one here, then I again will see another plate inside that will be medial pterygoid plate. This whole thing is the lateral pterygoid plate, and iske andar ek aur plate that is medial pterygoid plate. Both are extension from the sphenoid bone. We have this entire bone above the sphenoid bone, usi ka extension. We already said lateral pterygoid plate was forming one of the medial wall of infratemporal fossa. So that's lateral pterygoid plate. Remember one thing: whether it is medial pterygoid or lateral pterygoid, they will not take origin from medial pterygoid plate. Both lateral pterygoid as well as medial pterygoid, they will take origin from which plate only? The lateral pterygoid plate. The only difference is one is from the lateral surface and one is from the medial surface of the lateral pterygoid plate in the muscle mastication never mention about medial pterygoid plate. That has nothing to do with the muscle of mastication. So it's just the lateral pterygoid plate you need to focus on. But this muscle is not that simple, guys. Lateral pterygoid is having two heads. Medial pterygoid is also having two heads. Lateral pterygoid head होता है upper head and lower head. Medial pterygoid muscle which will be here I tell you that is having a superficial and deep head. Now understand some bony prominences here and that will clarify to you. Obviously the muscle which will be originating here from this is from the lateral surface of lateral pterygoid plate. This muscle is lateral pterygoid. हमने कल discuss भी किया था in the maxillary artery and all we said this is the but this is the lower head. This is the lower head of lateral pterygoid which is originating from the lateral surface of lateral pterygoid plate. Where is the upper head coming from? Upper head is coming from that crest. Can you see that crest over there, guys? I hope you all can see my pointer there. That crest over there is present where? On the greater wing of sphenoid. So this is called as a crest of greater wing of sphenoid. Simple. Crest of greater wing of sphenoid. Crest of greater wing of sphenoid is giving origin to the upper head of this muscle, which will come like this. Just think of origin first. Two heads. When you see it from the side, we have one upper head, one lower head. Upper head is coming from where? It is coming from the crest of the greater wing of sphenoid. There is a crest. Clearly you can see there is elevation there. There is a crest on the greater wing of sphenoid. And the lower head will come from lateral surface of lateral pterygoid plate. When this muscle goes backward, it is going to attach to the fossa. We already discussed that anterior surface of the neck of mandible is having pterygoid fovea. Mandible में. So it is going to insert on the pterygoid fovea and also to the capsule of TMJ. Temporomandibular joint का जो capsule होगा, it is going to insert to the capsule also. Getting my point? To the pterygoid fovea that is on the neck of mandible and also to the capsule of temporomandibular joint, that is the insertion. And nothing, should not be any problem in understanding the direction. The direction of this muscle is absolutely backwards. This muscle origin is there, insertion is here, is coming backwards here. It's coming backwards. But when you look at the lateral pterygoid muscle or medial pterygoid muscle, the thing about the attachment is, which you can understand by another section or another picture, when you see it from inside. So this is a very important image, guys, to understand this orientation of the pterygoid muscle. But this is a view from inside. You are seeing it from the posterior side of this mandible. The two muscles, that is medial pterygoid and that one is lateral pterygoid. You can see lateral pterygoid is coming backward and attaching to somewhere close to the TMJ. You know the pterygoid fovea and capsule. But can you see medial and lateral pterygoid muscle speciality that their origin is medial and the insertion is more toward the outside? That is very, very important. This is the confusion which everyone has, and I wanted to eradicate this once and for all. Lateral pterygoid, this one here, this lateral pterygoid, this medial pterygoid. Both these muscles are originating from pterygoid plate and they are inserting going toward the mandible, which is outside. So the muscle is not only running backward, the muscle is running outwards also, like this. They are running outwards also. They are running laterally also. Backwards and laterally. Did you understand the point? The muscle are coming backwards and they are going outward. Why it is important? Because imagine if this muscle and this muscle contract. Lateral pterygoid and medial pterygoid muscle will contract. So whatever they will do, elevation, rotation is fine. But when these muscles will contract, obviously this mandible will try to come close to what? To the pterygoid plate. It will try to come close to the pterygoid plate and the entire jaw will be shifted toward the other side. So by right lateral pterygoid and right medial pterygoid, when they contract, they will push the mandible to the other side. If I deviate my jaw toward the left side, toward the right side like this. So this deviation is by what muscle? It is done by the left lateral pterygoid as well as medial pterygoid. They contract and they take the entire mandible to the other side. They take the entire mandible to the other side. So that's one important thing about the pterygoid muscle that you can appreciate from this picture only, that they have an origin which is more medially placed and the insertion is coming more toward the outside. So if one side muscles are contracting, they will take the mandible to the other side. Okay. So if you understood this part here, let me write down about the lateral pterygoid first and then we'll discuss the medial pterygoid. Let's take them one by one only. Upper head, lower head, you can already see that the two heads here in the insertion. Lateral pterygoid. Origin is, again, which head are we talking about? If you are talking about the upper head, the upper head originates from the crest on greater wing of sphenoid. Crest on the greater wing of sphenoid bone. If we are talking about the lower head, then it is originating from the lateral surface of lateral pterygoid plate. No confusion there, guys, no confusion. Lateral surface of lateral pterygoid plate, that's a lower head. Then, what is the direction in which the muscle is running? Now remember both the direction. First, the muscle, you can see it is running backwards. That's one thing. This muscle runs backwards because it has to go toward the pterygoid fovea, it is backward. And then I showed you, it is also running laterally. This is something which many people don't understand. I hope you have an orientation now. That is running backward and it is running outward also. It is running laterally also to reach the mandible. Insertion. The insertion of the muscle is to the pterygoid fovea, which is present on the anterior surface of neck of mandible. Just writing it for the reference, guys. Pterygoid fovea, which is present on the anterior surface of neck of mandible, and it is also inserted to the capsule of TMJ, to the capsule of temporomandibular joint, to the capsule of TMJ, to the capsule of temporomandibular joint. Nerve supply, again, no surprises there. Lateral pterygoid is supplied by the nerve to lateral pterygoid, which is again coming from where? It is again coming from anterior division of mandibular nerve. And finally, action. The main thing is the action. Now, look at this, guys. show you this muscle once again. If I show you this muscle and a picture, then you will add something to its direction, that the muscle is running backward, fine. It is running lateral, fine. It is slightly running upward also, which you can understand just by the picture itself. The lower belly, if you see, here are the two head guys. You can clearly see the two heads of this muscle. This is the upper head, right? This is the upper head, and that's the lower head of this muscle. If you look at the lower head of this muscle, isn't it running slightly upward also? The entire muscle is running backward, but this is running upward as well. Whatever muscle we said which are running downward, like temporalis was running downward, masseter was running downward, so they were elevating the mandible. If this muscle is going upward, so when this muscle contract, it will actually pull the head in this direction, and that will happen in the opening of the mouth. The only muscle of mastication which will pull the head of mandible forward, and that also helps in the rotation and opening of the mandible also, opening of the mouth also, or depression of the mandible. Out of the 4 muscles of mastication, 3 will help in elevation, but only 1 muscle will help in depression, and that muscle is the lateral pterygoid. That's the only muscle which helps the depression out of muscle of mastication. Or why does that we have 3 muscles for elevation and 1 muscle for depression? Because depression is something in which you don't need to apply the force, guys. Imagine if you're sitting in my class and if you're sleeping there in front of your screen, then your mouth will open automatically. So gravity is good enough. Gravity can open the mouth. You must have seen people sleeping in the metros and trains, and their mouth is open because gravity will pull. All the muscle of mastication are relaxed, and gravity will pull the mandible down. So gravity can also do it. But if you have to say that one muscle of mastication which is doing it based on its direction, that is lateral pterygoid. So 3 action of lateral pterygoid based on the 3 direction. Because it is running slightly upward, so 1, it is depressing the mandible or opening of mouth. 2, it is running backward, right? It is running backward. So when this contract, it will take the mandible forward. So it is the main muscle for protraction. Retraction was done by temporalis. This is the main muscle for protraction because the direction of the muscle fiber is backward. And we saw that muscle was running outward laterally. So it also deviated the jaw towards the other side. Sideways movement. It pushed the mandible to the other side here. Like right lateral pterygoid will push the mandible toward the left side. So these are the actions of the lateral pterygoid based on its action, based on its direction of the muscle fiber. So action may, first of all, depression of mandible, or you can say opening of mouth. Depression of mandible or opening of mouth. I'm going to quickly repeat this thing. We'll take a feedback from you if you understood this not, because it's very, very important to understand the muscles of mastication. We have like in orthopedics also, that's a very, again, a common dislocation that people come with, that is a jaw dislocation. So for that, you need to understand the muscle of mastication and their action. Then only you will understand those clinical. Depression of mandible or opening of mouth, that is one action, guys. Then what? It is also responsible for the protraction. The muscle is running backwards, so obviously it will pull the mandible forward, protraction. And the third action which we'll say is pull the mandible to opposite side, which is called as sideways movement. It's called as sideways movement. Like usually while chewing, this movement is, like if you're chewing, think of it like you're chewing a chewing gum, so you're actually kind of rotating the jaw in this direction. So you're kind of opening the jaw, closing the jaw, and then you're moving a sideways movement also of the jaw. And that sideways movement is done by the lateral as well as medial pterygoid, which we will discuss next. But this is about the third major muscle of mastication, that is the lateral pterygoid. Coming to the last one. Okay. For the medial pterygoid, it is better to see it from the inner aspect. So I kept this picture for you. I took it from the Gray's Anatomy only, the student's face. So this time we are looking at, this again is what we're doing, that's the lateral pterygoid plate. They have removed the medial pterygoid plate, we're still looking at the lateral pterygoid plate. So the muscle, because we're seeing it from inside, so the origin of the muscle is from the medial surface of lateral pterygoid plate. Medial surface of lateral pterygoid plate, that's one origin here. Now this origin of this medial pterygoid muscle is basically for the head, that is a superficial head. Guys, maxilla bone, maxilla bone on the posterior side of maxilla, we have a tuberosity here on the maxilla. This tuberosity on the maxilla is called as the maxillary tuberosity. This is called as the maxillary tuberosity. This maxillary tuberosity will give origin to one head of medial pterygoid, which will originate from here. That's a small head here, but if you go from outside, that's a superficial head. Deep head will come from where? Deep head will come from the medial surface of lateral pterygoid plate. So one head of the medial pterygoid is coming from here, and one head will come from here, but from where? From the medial surface of lateral pterygoid plate. This tuberosity, obviously, this is the posterior part of maxilla, is called as maxillary tuberosity. Lateral pterygoid was having upper head and lower head. This muscle is having superficial head and deep head. Superficial head, say it again, that is from maxillary tuberosity, and deep head is from the medial surface of lateral pterygoid plate, and then this muscle will come downward. The name says medial pterygoid, it is attached to the medial surface of ramus of mandible and the angle of mandible, especially to the angle of mandible. I hope you can see both the head also better. Look at this head here, the one which I'm like putting an asterisk sign on. This is the deep head here, and this is a superficial head. Look at the superficial head is coming from posterior surface of this maxilla here, that is maxillary tuberosity. So this here is a superficial head, the one where I put a hash sign on here, and the one which is, that one is a deep head. Superficial head from maxillary tuberosity, deep head or under side. Coming from here, from the medial surface of lateral pterygoid plate, and you can see the muscle is running downward and laterally, just like masseter. Masseter was outside, medial pterygoid is inside. Direction is same. So this muscle is also running downward and backward of course, and inserted on which surface? On the medial surface of, especially to the angle of mandible. Not to the entire ramus, mainly to the angle of mandible, which you can again appreciate by looking at this picture. Look at this, that is the insertion of medial pterygoid muscle. I will organize all these muscles and all these images in a sequence, and then I'll send it to you. So just keep on understanding it here. Images I'll send it to you in a very proper way. So medial pterygoid is inserted where? On the medial surface of the angle of mandible. Slightly to the ramus also, slightly to the body also, but mainly on the angle of mandible. it is. Right? Beta masseter outside tha. Masseter was outside, this muscle is inside. So this is a medial pterygoid muscle, and again, three direction of the medial pterygoid. It is running downward, it is running backward, and then we saw in that picture that it is also running outward, lateral. So one action is just like lateral pterygoid only. It will also help in the deviation in the sideways movement. Apart from that, the other two actions are just like masseter muscle. कोई difference ही नहीं ना? Masseter muscle is also coming downward and backward, and medial pterygoid is also coming downward and backward. So the action, something has to be changed to be the same. So medial pterygoid will also help in the elevation of mandible and slightly in the protraction. You just have to think in the opposite direction. If a muscle fiber is running in this direction, the action will be opposite. So the muscle will take the mandible upward and slightly forward also. So medial pterygoid action is what? Elevation of mandible, protraction of mandible, and sideways movement. Sideways. What is the medial pterygoid? Again, two head beta. One is superficial head. Superficial head. What was the tuberosity? Maxillary tuberosity. That is maxillary tuberosity. That is why I never discuss the entire osteology of the head and neck together. We are kind of adding, every day we are adding something to osteology. Someday maxillary tuberosity, someday pterygoid plate, someday something, sometimes zygomatic arch. When we talk about the nose, we'll talk about the turbinates. When we talk about the orbit, we'll talk about the fissures. And by the end of it, you don't have to, like, especially read the normal lateralis or normal frontalis part, it's covered. Everything is covered in it. If you have additional thing on the osteology, we can always discuss it, but it is very boring to discuss the osteology without knowing anything about it. Imagine you're discussing normal lateralis and you're trying to remember the muscle origin temporalis is from here, lateral pterygoid is from here, without knowing that how these muscles will be running, where they will be inserting, what will be their action. What's the point here? What is red or blue color? You just have to understand the entire muscle as a whole. I always say, when you talk about the muscle, you should look at the origin, look at the insertion, try to understand the direction of muscle fiber, and you never have to mug up the action of any muscle. There are like 750 muscles in the entire body. How can I possibly remember the action of every muscle? You ask me any muscle instantly and I can tell you the action. The reason is because I have this picture in my head that what is the direction of the muscle fiber, and that can help me to understand that what the action would be. But at superficial head, maxillary tuberosity, deep head is coming from the medial surface. Medial surface of which plate? Lateral pterygoid plate. Medial surface of lateral pterygoid plate. Direction. This muscle direction is just like masseter. It is coming downwards. It is going backwards, of course, downwards and backwards, and laterally. I really hope you have laterally wala concept samjh aaya ho, that the muscle origin is medial and the insertion more outside on the mandible, so it is running laterally also. Downward, backward, and laterally, and that's why the action of this muscle will be elevation of mandible. I don't have to write the entire thing. Elevation of mandible, protraction of mandible, and sideways movement. Sideways movement, just like lateral pterygoid. This will basically help the lateral pterygoid to deviate the jaw to the other side. Right medial pterygoid obviously will push the mandible toward the, or will take the mandible toward the left side. Sorry, nerve supply. Now we got a nerve supply. Well, that's one exception here. We said all the muscle of mastication are by the anterior division of mandibular nerve. This is by the trunk of mandibular nerve. Nerve to medial pterygoid is coming from the trunk of the mandibular nerve. Temporomandibular joint topic is just a 15 minutes topic. 15-20 minutes maximum. Yeah. Main thing is this only. Every college is having one lecture for TMJ and the muscle of mastication. The maximum time is to understand the muscle of mastication only. TMJ is very easy. It's very easy to understand TMJ. And despite of having a complete lecture for that, I mean, what I have noticed, I don't know whether you have the same problem or not. People don't understand the action of these muscles or try to mug up the actions here. But I really want you people not to do that mistake. Please understand the direction of the muscle fiber, visualize it, and then see what the action possibly could be. Let's have a very quick recap, and then I will take a feedback from you that if you understood all the attachment. Let me just start with this, guys. Let me start with what muscle here? That is the temporalis muscle. Now, I want you to please close your notes and just kind of pay attention to the screen and just speak to yourself. The origin of temporalis muscle is from the entire temporal. It's a fan-shaped muscle. It's the largest muscle. So it is from the entire temporal fossa and also from the temporal fascia, which is covering it. Temporal fascia is bahar hoga aise. So it is taking origin from the temporal fascia also. The muscle is going downward, deep to what? Zygomatic arch. It will go medial to the zygomatic arch, or you can say deep to zygomatic arch, and will insert where? It will insert to the tip of the coronoid process, to the medial surface of the coronoid process, and to the anterior border of ramus of mandible. Which tells me the direction of this muscle fiber is, we have the two major directions to be noticed here. That is this one and this one. All the three fibers we say, anterior, middle, and posterior. But those fibers which are running downward, they will help you to lift the mandible. That is, elevation of mandible will be done by, so one action will be what? Elevation of mandible. And the direction of this muscle will forward, it will pull the mandible back. So retraction also will be done back. Retraction of the protruded mandible, the mandible which has already gone in front, it will pull it back. That is what it is, that is the temporalis muscle. Second in the line, masseter. Masseter muscle, three fibers, and out of the four muscles, this is the muscle which is mainly asked, guys. Three layers: superficial layer, middle layer, deep layer. Some books just simply say superficial and deep layer, but usually we say superficial, middle, and deep layer. But a superficial layer will take origin from the lower border of, look at that, lower border of anterior 2/3 of zygomatic arch. Middle fiber will take origin from lower border of posterior 1/3 of zygomatic arch. And of course, the deep fiber will be taken from the deeper surface. You can say deep surface, or you can say medial surface of zygomatic arch. Ultimately, muscle will insert where? On the outer surface of the ramus of mandible. Pura ramus of mandible cover kiya hua hai. That's the ramus of mandible. And if you look at the direction of this muscle fiber, the important to note is it is running downward and backward. So action is opposite. So it will do what? what? The masseter muscle will do what? It will help in the elevation of mandible and it will help in the protraction of the mandible. It will help in the elevation and the protraction. Lateral pterygoid. But a lateral pterygoid muscle ke liye, let me use this picture only for lateral medial pterygoid. How about we go with this? Lateral pterygoid muscle is having two heads. Which two head? We have an upper head and we have a lower head. Upper head origin is from where? From the crest, which is present on the greater wing of sphenoid. Lower head is coming from the lateral surface of ramus of mandible. Lateral surface of ramus of mandible. Lateral surface of lateral pterygoid plate. I'm sorry. Lateral surface of lateral pterygoid plate. And then these two heads are converging toward backward, and you can clearly see it is attached to the neck. What is the fovea beta? What that fovea is a pterygoid fovea, and also inserted to the capsule of the TMJ. Also inserted to the capsule. We have some remnant of this muscle inside the TMJ, which we will discuss in a while. But right now, remember the two heads are converging toward the pterygoid fovea and to the capsule. If you look at the direction is backwards. So that means this will protrude the mandible. Obviously, it will pull the mandible forward one. This lower belly is coming upward here, so it will help in the opening of mouth or depression of mandible. The only muscle of mastication helping in the depression. And then we said something about lateral medial pterygoid because they are running outward, so they will pull the mandible to one side. So unilateral, if one side lateral pterygoid and medial pterygoid is acting, so they will push the mandible, or you can say they will deviate the jaw toward the opposite side. Finally, medial pterygoid muscle, the one which I'm highlighting here is the superficial fibers. Let me just only highlight that. That's a superficial fiber and deep fiber. Superficial fiber originate from what tuberosity? Maxillary tuberosity. Deep fiber originate from the deeper surface or medial surface of lateral pterygoid plate. Muscle is running downward and backward and coming to the medial surface of what? What is that? Angle of mandible. It is inserted to the medial surface of angle of mandible. But action kya hoga? Masseter muscle. Just think about masseter muscle. Masseter was also running in this direction only. The only thing is masseter is outside, medial pterygoid is inside. So the two muscles with the name M, masseter and medial pterygoid, the direction is almost the same. So this will also help in the elevation of mandible. It will also help in the protraction of mandible. And once again, just like lateral pterygoid, it is going outward, so it will deviate the jaw toward the opposite side. The TMJ, temporomandibular joint. Well, the type of joint TMJ is, it is a condylar joint. It is a condylar joint which comes under the synovial category. This is something we have discussed in general anatomy also. Fibrous joint, cartilaginous joint, and synovial joint. So it is a synovial joint, but which type of? It's a condylar joint because it is made up of the condyle of the mandible. Now to understand the articular structure, whenever you talk about any joint, whenever you write answer for any joint, if I tell you about the answer point of view, you should be writing about the type first, then the articular structures, then the support system, and then obviously about the muscles and the action which are produced at the joint here. So second thing is the articular structures. Articular structures. Let me paste a picture first, then we're going to draw it schematically also. Just try to understand the articular structures on this picture base, and then as I said, we will be discussing it separately as well. Now all of you just pay attention to the TMJ. Now don't look at any other thing. Let me just kind of enlarge it even further so that you can just focus on the temporomandibular joint. Guys, this tubercle here, this elevation that is present in the lower border of zygomatic arch. Zygomatic arch is cut here. The zygomatic arch will be present like this. This tubercle which is present in the lower border of zygomatic arch is called as the articular tubercle. This is called as the articular tubercle. The articular tubercle, that is, which is there one. Secondly, this fossa here is called as the mandibular fossa. It's a part of temporal bone. Look at this, guys. It's a part of temporal bone, and there's a depression in that so that the head of mandible can come into it. So we call it mandibular fossa. Part of temporal bone, squamous part of temporal bone, and that fossa is called as the mandibular fossa. And posteriorly, what you see, this external auditory canal is lined by this plate. This plate is called the tympanic plate. This plate is called the tympanic plate. This is called the tympanic plate. Articular tubercle, mandibular fossa, and tympanic plate are there. But see, tympanic plate will not participate in the formation of the TMJ. I'll tell you how. This is the head of mandible. There is no confusion about that. That's the head of mandible. Now, what you will see when you look at the capsule of the temporomandibular joint, I'm going to draw it all separately for you. Just understand it here. If you look at the capsule of TMJ beta, it is attached from the articular tubercle to the neck. You can see that it is attached from the articular tubercle to the neck, and posteriorly it is attached from the neck to the posterior part of mandibular fossa. See, it is attached to the mandibular fossa only. It is not attached to the tympanic plate, which is a good news. Why it is a good news? Because you have a space now between the head of mandible and the tympanic plate. Now imagine if there is no space here. Look at this. I hope you can see the pointer there. If there is no space over there in between the head of mandible and tympanic plate, and if this capsule is attached to tympanic plate only, the problem is even a slightest of retraction injury. Zara bhi retraction injury hua, zara bhi head of mandible piche gaya, it will fracture the tympanic plate. If somebody gets punched on the chin, if you get punched on the chin, your mandible will go backward. And if your mandible goes backward, obviously your head of mandible can bang against this tympanic plate and can fracture the tympanic plate. So that is why we are gifted with a space in between, and that space is filled with the adipose tissue. We have a lot of adipose tissue in between here, which is providing the cushion here. Although still it is very common to have a fracture of tympanic plate if somebody gets punched on the chin. Now if somebody gets punched on the chin from the side, that's a different story. That different ligament, lateral ligament is ruptured. But when a person gets punched on the chin from the front like this, so mandible goes backward, this head of mandible will crash against this tympanic plate, and the fracture of tympanic plate will take place, and sometimes that can even lead to the rupture of the tympanic membrane inside. The tympanic membrane, the eardrum can also rupture because of that. So just have to understand what are the things which are like close by. That's one important thing. The capsule of the TMJ attachment, if you look at it, it is not attached to the tympanic plate but to the mandibular fossa, the posterior part of mandibular fossa. The most unique thing about TMJ is this. Can you see this? Something inside, guys, that is called as a fibrocartilage, that is called as an articular disc. I'll be writing this as I said, just look at the picture here. That over there is called as an articular disc. But an articular disc is like a fibrocartilage. Now you will say fibrocartilage तो बहुत joints में होता है, like glenoidal labrum is a fibrocartilage, acetabulum में we have fibrocartilage there around it, menisci knee joint में the menisci are fibrocartilage. So what is so special about it? Two things. First of all, this fibrocartilage which is present inside, it is actually the remnant of tendon of lateral pterygoid. Can you see the continuation there? It is basically the remnant of the tendon of lateral pterygoid muscle only. So this articular disc in the TMJ has something to do with the lateral pterygoid. That is, it is a remnant of the tendon of lateral pterygoid. Number one. Number two, this articular disc is why it is so special, because this articular disc is neither attached to mandibular fossa nor it is attached to the head of mandible. बीच में हवा में ऐसे. Mandibular fossa is like this above, head of mandible is below. So this articular disc is neither attached above nor it is attached below. It is in between the joint. It is basically dividing the joint cavity in two parts. We have an upper joint cavity which is here, somewhere here, and we have a lower joint cavity. Now what is the advantage? The advantage is that now you can use both joint cavities for the articulation for the movement. And let me explain to you how it is. If let's just pay attention to me. If let us say this here is the articular disc. Look at this, my hand, let's say is the articular disc and this is the head of mandible for me. Now when I'm doing movement like protraction, retraction or sideways movement like this. Sideways movement or protraction, retraction. These are called as a sliding and gliding movement. We just have to go forward, backward or sideways. So these movements are called as sliding and gliding movement. In the sliding and gliding movement, your articular disc and head of mandible, they move together. Like this, they are moving together. So that means movement is taking place in which cavity? In the upper joint cavity. Friction तो सिर्फ यहाँ पे हो रहा है ना अभी, because they are moving together, so there is no friction between them. So sliding and gliding movement, retraction, protraction, sideways movement, it takes place in this cavity here. Whereas the rotatory movements like opening and closing of mouth, this is rotation. This head of mandible will rotate here. This rotatory movement of closing and opening of mouth will take place in the lower joint cavity because only head of mandible will move and not the articular disc. So that is a great advantage of having an articular disc in which you can use both the surface of articular disc for the articulation. Upper surface you are using it, or upper joint cavity you are using it for what? Sliding and gliding movement. Lower joint cavity you are using it for, you are using it for the rotatory movement of closing and opening of mouth. And that is how we are not subjecting too much of friction on one surface of the articular disc. Sliding gliding is taking place on this surface and rotation is taking place on this surface, so the chances of arthritis on the temporomandibular joint will decrease because not every movement is taking place on one surface only. Some on this side, some on this side, thankfully. And that's the advantage of having this articular disc or the fibrocartilage with EMJ. Let's first talk about this part here and then we'll talk about the support. So as I said, the temporomandibular joint, it is a condylar joint. So articular surfaces, when I write about articular surface, upper articular surface is the articular tubercle. Do mention it, it's very important. You will understand why it is so important. Articular tubercle and anterior two-third of mandibular fossa. Anterior two-third of mandibular fossa. From that, I told you entire mandibular fossa is not used for the joint. There is a space behind it. There is a cushion behind it, so that it is not hitting against the tympanic plate. So articular tubercle and anterior two-third of mandibular fossa, that is upper. Lower articular surface is by what? It is by the head of mandible. Simply. It is by the head of mandible. If I just quickly draw it for you, because obviously you have to draw it in exam also. This here is the articular tubercle below. Here is the mandibular fossa. That is external auditory canal. But I'm writing in short, that is the articular tubercle and this is mandibular fossa. Articular tubercle and mandibular fossa, and this of course is the external auditory canal. Lower articular surface, there is a head of mandible. I'm purposefully drawing it slightly away from it so that I can show the structures inside. That's the head of the mandible. Capsule, the attachment of capsule, I mean, I'm just drawing it here, no need to write it separately, you can when it is needed in the exam. So this capsule is attached from the articular tubercle to the neck, and then we set from the neck to the junction of anterior two-third and posterior one-third of the mandibular fossa. Speciality of this joint is the presence of the fibrocartilage inside. The presence of this fibrocartilage inside. I will be discussing this fibrocartilage a little separately. And to remind you, what muscle was coming and inserting like this? The one which is inserted to the capsule and also to the pterygoid fovea backward. That was lateral pterygoid muscle is inserted. So that it will remind you, it's a component of this muscle only. This muscle is lateral pterygoid. That is articular disc. Articular disc, we said structurally it is a fibrocartilage. Structurally it is a fibrocartilage. This articular disc is a fibrocartilage. And when you look at the shape of this articular disc, it is not exactly like this. We have some bands also, some thickened band as well in between. Like, just to tell you a little detail about the articular disc, how it look like. Let's say there is a capsule in front, there is a capsule behind. So this articular disc will be, like we have anterior area, then we have anterior thick band, then we have intermediate area, we have this posterior thick band, and then with the posterior part is bilaminar. Again, it's not very important to know that what exactly the shape of this articular disc for us, but we should know that, okay, when you look at the articular disc in detail, it's not like a simple fibrocartilage band over there. It is having certain parts which you can label if you want. This part here is called as an anterior part. This is called as anterior band. The thickening is called as anterior band. This is intermediate part or intermediate band, not band, sorry, intermediate part. This here is the posterior band. So you can see there are two bands, there are two thickening that you will notice. Obviously giving strength to this articular disc, there is an anterior band and there is a posterior band. And then more posteriorly, you have a bilaminar part. Bilaminar part of the articular disc. So these are like, that's they say that they are part of the articular disc. We have anterior part, we have middle part or intermediate part, and we have posterior part. Posterior part is bilaminar. This is the posterior bilaminar part. Let me put them in the same highlighter here. Anterior part, there is intermediate part, and there's a posterior bilaminar part, and these three parts are divided by what? By the two bands in between. It's a circular disc, it is a circular disc. So we have two thickening in between. Like we have an anterior band like this, and we have a posterior band like this, which divides the entire articular disc in three areas, the three zones: anterior zone, intermediate zone, and posterior bilaminar zone or bilaminar part, whatever you want to call it. Now we said, what is the advantage of the articular disc? The advantage that we have to discuss, the main thing of articular disc is, it is, first of all, we said one important thing is that it is the remnant. It is a remnant of tendon of lateral pterygoid. It is the remnant of tendon of lateral pterygoid. Number two, it is also, it divides TMJ. It divides temporomandibular joint in two joint cavities. We have an upper joint cavity. We have upper joint cavity, and we have lower joint cavity, upper and the lower joint cavity. We already discussed, guys, upper joint cavity will allow what movement? It will allow the movement of sliding and gliding. Sliding, gliding movement are taking place in the upper joint cavity, and rotatory movement mainly. Rotatory movement like closing and opening of mouth are taking place in the lower joint cavity. Sliding and gliding lower joint में भी होता है. Lower joint cavity also allows some sliding and gliding, but it is mainly for the rotation. Upper joint cavity is purely for sliding and gliding. So when I say sliding, gliding, what is the meaning here? Articular disc and TMJ. Articular disc and head of mandible, they are moving together. So that is the movement taking place in the upper cavity. The friction is only above. Rotatory movement, only head of mandible is moving, not articular disc. Now I can say movement is taking place in the lower joint cavity. That's the advantage of having this articular disc. It is dividing the frictional forces into cavities. Now coming to the supports of the temporomandibular joint. What are the supports of the TMJ? Some ligaments and all that. What are the supports of TMJ? There are two types of support that you'll see in the temporomandibular joint. One, we have some true supports, and then we have some modified support or false support. If you call it false support, if you call it modified support, doesn't matter, same thing. True and modified support. Now what is a true support? For any joint, you take any XYZ joint in the body, the true support is always its capsule first. Shoulder joint capsule, the major support, the true support. May not be the main support, but the true support. Elbow joint capsule, knee joint capsule, hip joint capsule, unke capsule unke major support hai. So the first thing is the capsule. Now I'm not writing anything about the capsule because you already know how capsule is attached. From articular tubercle to the neck, and then from neck it is extended posteriorly to the mandibular fossa, but not to the tympanic plate. It is not going to the tympanic plate. Now the thing about capsule is, there's one very interesting fact about capsule which you should write like this: LL upon TT. इसको ऐसे आप रखो, easy रहेगा. LL by TT. LL by TT. Now what this LL by TT is representing? LL reminds you of, LL stands for loose and laxative, and then upon abaton, tense and thick. This is the property of the capsule of TMJ. The capsule is loose and laxative in the upper part, and the capsule is tense and thick in the lower part, which makes sense also, because upper joint cavity is allowing the sliding and gliding movement, so beta upper wala capsule should be loose to allow those movements. Lower joint cavity is allowing the rotatory movement, and rotatory movement are around one axis only. It's one axis, and the movement is around one axis. You don't have to go anywhere, forward, backward, anywhere. So that's how the capsule is also organized. That upper part of capsule is loose and laxative. Lower part of capsule is tense. LL by TT. Loose and laxative, tense and thick. Upper part will loose and laxative, lower part will tense and thick. The second major support of TMJ is a ligament which is called as the lateral temporomandibular ligament. Lateral temporomandibular ligament. Let me very quickly show you that ligament, and then we can draw it in a schematic fashion also. Look at this ligament here. Is the lateral ligament. Look at this ligament, the one which I'm highlighting here. This is the lateral ligament. So what you see, this lateral ligament is basically again attached to what? It is attached to the tubercle, that is to the articular tubercle. Then it is coming downward and winding around the neck of mandible laterally and posteriorly. Laterally and posteriorly. It is winding around the neck laterally and posteriorly. It's very important to understand the direction of the ligament. Again, direction of the muscle always tells you about that what is the action of the muscle. Direction of the ligament always tells you that which movement it is going to restrict. One example, although this is a very simple and basic thing we all know, but just to, always when you look at the pictures, when you look at any images in the atlas, this is one thing that you should keep in your head. Now imagine, guys, this is a bone here. Look at this water bottle here. This is a bone, right? And there is a muscle. If a muscle is running toward this bone like this, holding it, and it is running in this direction. So when this muscle will contract, it will obviously take this bone in the opposite direction. The direction of muscle fiber, opposite is the action. It will take the muscle, this bone in this direction. But ligament is doing the exact opposite. If this is a ligament running in this direction and holding this bone here, so ligament is not going to allow this mandible or this bone here to go further away from. So whatever direction the ligaments are running in, the same direction they are preventing the bone from going from. if the ligament is directed backwards, so it will obviously prevent the retraction of the mandible. It will not allow the mandible to retract from the normal position. And that's good also, because if you retract the mandible from non-normal position, then obviously again the problem is there. Tympanic plate is behind. So that is the lateral ligament. Wherever you wrote this lateral ligament, guys, just draw this small diagram here. That's articular tubercle, the mandibular fossa, the auditory canal. So this lateral ligament is starting from this articular tubercle like this, lateral temporomandibular ligament like this. It is running downward, laterally and backward. It goes laterally and backward and surrounds the neck of mandible from the outer aspect and from posteriorly also. It is basically holding the neck of mandible. Okay, I'll just hold it here like this. I will not allow you to go back. So this is the lateral ligament or lateral temporomandibular ligament. And as you can see, the direction of this ligament, it basically prevents hyper-retraction. It mainly prevents the hyper-retraction. It will not allow the mandible to go beyond the normal position or not neutral position. When the mandible is protruded, temporalis will pull it back till here. But it should not go beyond the neutral position, and that is the job of lateral ligament. That is the job of lateral ligament. So when I was telling that somebody get punched on the chin, so when somebody get punched on the chin very hard, so obviously first this ligament will break. And once the ligament will break, the mandible obviously can go backward now, and that will hit the tympanic plate and can cause the fracture of the tympanic plate. Posterior dislocation of the TMJ is usually associated with the fracture of tympanic plate. Not obviously. Posterior dislocation of TMJ is usually associated with the fracture of tympanic plate. So that is what ligament, that is a true ligament. So when you talk about the true support, there are two true support. One is the capsule, and then this ligament which is coming from the articular tubercle and surrounding the neck of mandible, which prevents the hyper-retraction. What about the false ligament, guys? And why do we call them false ligament? False ligament are those which are not directly supporting the TMJ, which are not directly in relation to the capsule here. Now look at this picture. You're looking at the two ligaments there, which are from the inner side. You're looking at the ramus of mandible from the inside now. Well, I hope you know this much of osteology, guys. This here is what process? That is the styloid process. And this ligament here is called as the stylomandibular ligament. It is attached to the angle of mandible, stylomandibular ligament. This projection, the one that you see above here, I'm going to draw it schematically also for you. Just look at this. This is the spine of sphenoid bone. Spine of sphenoid is the most posterior part of the sphenoid bone. If somebody wants to identify the spine of sphenoid in the base of skull, I guess our next lecture is on the norma basalis also. So only then I'll tell you that. Spine of sphenoid is the most posterior part of sphenoid bone. If you want to identify the sphenoid bone on the base of skull, that's the easy way. And from the spine of sphenoid to a bony projection here, there is a small tongue-like bony projection which is called as lingula. Lingula is a small bony tongue-like bony projection which is basically covering the mandibular foramen. Remember that there is a mandibular foramen over there from where the nerve and artery will go inside. So that is called as lingula, and this ligament is called as the sphenomandibular ligament. Sphenomandibular ligament, stylomandibular ligament from the styloid process, and from the spine of the sphenoid to the lingula on medial surface, it is called as sphenomandibular ligament. Now what you see, both these ligaments are not in relation to TMJ. They are not supporting the capsule, they are not reinforcing the capsule, but still they are holding the mandible, they are helping to hold the mandible. And that is why they are called as a false support, because they are not in direct relation, so we call them the false support. Stylomandibular and sphenomandibular ligament was in the rule of two for investing layer of deep cervical fascia. Two muscles, two spaces, two glands, two ligament also. These two ligaments are the modification of investing layer of deep cervical fascia. Stylomandibular and sphenomandibular ligament are the modification of investing layer of deep cervical fascia. So wherever you wrote those false ligament or the modified support, modified support may just write and draw also. So modified support may, we said we have two ligaments there. One is the stylomandibular ligament, and we have sphenomandibular ligament. If this again is a medial surface of ramus of mandible, whatever we just saw, I'm trying to replicate the same only. So one ligament will be coming from the styloid process, let's say this is a styloid process, and one will be coming from the spine of sphenoid to the lingula. A bony projection on the medial surface of ramus of mandible is called as the lingula. This here is the spine of sphenoid. This is styloid process. So from the styloid process, the ligament is going where? It is going to the angle of mandible. And this is from the spine of sphenoid to the lingula. This is number one in our list, that is stylomandibular, and this is number two in our list, that is sphenomandibular ligament. The two false support of TMJ, the two modification of investing layer of deep cervical fascia. So I hope you understood the structure of the TMJ, about the articular disc, support system, the true support and the false support. These are the two false support we have, or modified support. Muscles and action we have already discussed. I don't have to discuss separately. You already know which muscle and what action they are going to produce on the TMJ. All we have to do is that we got to write them on the basis of their action. We saw the name of the muscle and what is the action. Now we will look at the action and what all those muscles, which all muscles are causing that action here. We will write them together here. So guys, if you're done with this, so let's talk about the movements and the muscles. Which muscles are causing it? So it's your turn. Guys, movement. Let's start with the elevation. You know what is elevation? That is closing of mouth. Elevation or closing of mouth. We said there are three muscles which are causing this. One was the temporalis. Any muscle which will go downward obviously will elevate the mandible. So which three muscles are going downward? Temporalis, masseter, and medial pterygoid. Correct? Depression, that is the opening of mouth. As I said, the muscle of mastication, which is responsible, the only muscle which is having a belly going upward is lateral pterygoid. So that's unique here. Lateral pterygoid is the only muscle which is causing the depression. But the important thing is, if you have to excessively open the mouth, like look at me guys, that's a normal opening of mouth. Like, but if I excessively want to open the mouth, or if I want to open my mouth against the resistance, if I put a pressure below and then I try to open my mouth, then lateral pterygoid muscle alone is not enough. इसको help चाहिए. Lateral pterygoid will need help from the muscle which are present below. So these muscles will also pull the mandible downward, like anterior belly of digastric, mylohyoid, geniohyoid, whatever muscle we just saw attached to the mandible, those muscles which will pull the mandible downward will also help the lateral pterygoid in opening of the mouth, but when it is against the resistance. Normally lateral pterygoid is enough. So against resistance, apart from lateral pterygoid, वो तो काम कर ही रहा है, apart from lateral pterygoid, we will be needing anterior belly of digastric, mylohyoid, and geniohyoid muscle also. These muscles which are present in the floor of mouth, they will also help to pull the mandible downward. They are basically helping the lateral pterygoid to open the mouth or to depress the mandible against the resistance. Protraction. The muscle which are going backward will protract the mandible. The main muscle which is going backward is lateral pterygoid again. The main muscle which is for the protraction is lateral pterygoid. Yes, it is helped by which muscle also? Which two other muscles are also going slightly backward, not as like lateral pterygoid? That was the medial pterygoid and masseter. You can always go back and look at those muscles you've written. These muscles are also causing the protraction. And therefore, the retraction to its normal position is a unique function of which muscle? Temporalis. Because if you remember, temporalis is the only muscle which is having a horizontally forward running fiber. So retraction is. And then sideways movement. Sideways movement is done by the lateral and medial pterygoid moves. And when I say sideways movement, guys, do remember it? Deviation of jaw toward the opposite side. Right lateral pterygoid, right medial pterygoid will deviate the jaw toward the left side. That is sideways movement. This is all done, right? We understood this action and we already discussed this. Just to finish it off, guys, nerve supply and the blood supply of TMJ. बहुत simple है. So these are the things which we already discussed, and I just need to remind you again. Nerve supply of TMJ. Where we talk about the nerve supply of TMJ? What now, guys? Auriculotemporal nerve. Remember 4 things. Auriculotemporal nerve was supplying the skin of the auricle, temple, parotid gland, and TMJ also. So the main nerve supplying it is the auriculotemporal nerve. Is a major nerve supplying it, which is coming from the posterior division of mandibular nerve. It is a branch of mandibular only. And there's another branch of mandibular nerve which supplies it, and that nerve is the masseteric nerve. Coming from mandibular only, from anterior division, that is from posterior division, this is from anterior division. Nerve which is supplying the masseter muscle. Nerve to masseter also supplies TMJ. You can always go back to the mandibular nerve, back into the notes, and you can write it there also. That the nerve to masseter, the nerve which supplies masseter also supplies TMJ. Masseteric nerve also supplies TMJ. Blood supply or easier. Blood supply, it's very easy to remember, guys. What are the two branches of external carotid artery you will see in close relation to TMJ? The two terminal branches. What are the two terminal branches? The maxillary artery, the superficial temporal artery, and they both will supply. So branches from maxillary and superficial temporal artery. Nerve supply done, blood supply done. And lastly, about one clinical that I should tell you here. What is the most common dislocation of TMJ? You know the most common, we said if there is a posterior dislocation that can cause fracture, but that is not most common. The most common dislocation of TMJ, the most common dislocation, this is a sign for dislocation. This is a sign for dislocation. The most common dislocation of TMJ is anterior dislocation. Anterior dislocation is most common. And you know how come a person has the anterior dislocation? When a person tries to open the mouth excessively, if you try to open the mouth excessively, too much more than it is required, then the head of mandible will come in front of the articular tubercle. Head of mandible will come in front of the articular tubercle. If I once again show you that picture over there, this head of mandible, this will come in front of the articular tubercle like this. That's an articular tubercle. That is anterior dislocation. If you try to excessively open the mouth, then obviously this head of mandible will rotate like this, and this will come in front. That is anterior dislocation. And how to it's a day-to-day procedure how to reduce this dislocation. So the patient will come to you with open mouth, wide open mouth. वो mouth बंद नहीं कर पाएगा अपना. So anterior dislocation, the patient will come to you with a wide open mouth. What you will do, you will put your thumb onto the last molar tooth. आप दोनों हाथ उसके मुंह में डालोगे. You put both the thumb on the last molar tooth. You press it downward. You press the jaw downward, and then backward and release it. That's it. You just have to basically take the head below and then backward and leave it. It automatically cut into this. The temporalis muscle will anyways is pulling it. It will pull it back into the cavity here. You put both your thumb onto the last molar tooth inside like mouth already open. You put the thumb there. You push it down. Push it backward and release it. Automatically, the dislocation will be reduced. So excessive opening of mouth can lead to the anterior dislocation. If you will yawn too much in my class, you can have anterior dislocation. So you better be taking care of that. Right? Excessive opening can lead to anterior dislocation. Guys, pharyngeal arches basically is an extension of the mesoderm only in the future neck region. I mean, if you look at this, the first picture here, that you see they're showing this. This is the developing eye over there, and this is the first arch, right? This is the right, that's first arch here. They're showing the first arch is being developed. That will be a stomatodeum here. That is the opening of the mouth will be there, and this is the first pharyngeal arch developing. So it's basically the mesoderm only, which will extend anteriorly and toward the midline from this side as well as from that side. Folding of the embryo takes place craniocaudally also, and there's a lateral folding of the embryo also. So like first pharyngeal arch, it was running forward like this, but because of the folding, these two pharyngeal arches will come from and meet in the midline. That is first arch. Second arch, third arch, fourth arch. That's how the pharyngeal arches are present, and they are fused ventrally. Dorsally they are separate, but ventrally, anteriorly they are fusing with each other here. In this picture, you can see the first arch, which starts on the 21st day. Actually, the first pharyngeal arch appears at the end of the third week. That is on the 21st day, and then by the 29th day, everything like on the 30th day, all the pharyngeal arches actually they comes into the picture. You can see them. First arch is there, second arch is there, and like many other structures in the embryology, they also develop from cranial to caudal side. They start from the cranial side, like you can see one arch there, then second arch there. If you look at this picture here, you can see more. You can see first arch, second arch, third arch is also there. You see this picture here, you can see the first arch, second arch, third arch, fourth arch. Fourth and sixth arch, it is very difficult to separate these two. So the three arches which will be very easily visible, very easily you can recognize in the embryo are the first, second, and third arches. Fourth and sixth, they're kind of not easily differentiable here. Fifth arch disappears, so we are not talking about it. In many people, fifth pharyngeal arch is not formed. In some people, it starts to form and then it disappears. So guys, look at these kind of finger-like projections which are developing in the future neck here, and they're running forward and then meeting in the midline anteriorly. Right, that's how the pharyngeal arch is. So if you want to look at the picture of a pharyngeal arch and to understand this, you have to take a coronal section. Please understand. अगर आपको ये section समझ में आ गया, the rest of the part will be easy. Pharyngeal arches off the right side, pharyngeal arches off the left side. They're fusing like this, and they're present in the future neck region. Now, how will you appreciate all the layers of pharyngeal arches is by taking coronal section. If I take a section like this, if I take a section like this, then I'll be looking at like this, the pharyngeal arches in this way. So it will be like first arch, second arch, third arch, fourth arch, sixth arch. That's how the arches will be here. Now, what do you see? These pharyngeal arches, beta, from the outer aspect, they're covered with the ectoderm. Ectoderm on all the pharyngeal arches. On the inside of the pharyngeal arch, we have endoderm. And in between, we have core of mesoderm. So when you look at one pharyngeal arch, it is having everything. It is having ectoderm, it is having endoderm, generally, and we have a core of mesoderm inside here. So our, the purpose of this lecture is to understand that what that ectoderm will give rise to, what that endoderm will give rise to, and what will be developing inside the mesoderm of those respective pharyngeal arches. So there we go. This topic is going to be very simple for us, because the difficult part of this topic is understanding pharyngeal arch arteries, which thankfully we have discussed in the cardiovascular system, and what are the muscles which will come under those pharyngeal arches. For that, one should know about cranial nerves. That also we have covered. So because we know about the muscles, we know about the blood vessels, we know about the nerves supplying the pharyngeal arches. So this is not going to be a difficult topic for us at all. So as I said, pharyngeal arches, when you see the pharyngeal arches, the picture will go something like this. This is the first arch, second arch, third arch, fourth arch, sixth arch. And try to notice the color where I'm using it and what difference you can see here. That's arch of one side here. First arch, second arch, third arch, fourth arch, sixth arch. And as I said, all these pharyngeal arches are going anteriorly and they're fusing in the midline also, which I am not bothered about right now. I will discuss that in the development of tongue. Don't draw this, guys. These pharyngeal arches will be meeting with each other ventrally, in front. Don't draw this part. Just don't unnecessarily increase your workload. Let us say this red color here, it represents the ectoderm of a pharyngeal artery. This is first, second, third, fourth, and sixth. First, second, third, fourth, and the sixth arch. Let us say this red color represents the ectoderm, and this blue color, it represents the endoderm of pharyngeal arch. Now, I hope you've noticed something special about the first pharyngeal arch, but the first pharyngeal arch is covered with the ectoderm on both sides. Majority of the books of embryology have given it wrong. They show ectoderm on the outside and endoderm on inside of all pharyngeal arches, but this is a very well-known fact that first pharyngeal arch is covered with the ectoderm on both sides. It's very important that your first pharyngeal arch is covered with the ectoderm on both sides. It is covered with the ectoderm on both sides. So we have ectoderm on the outer side, endoderm on the inner side, except the first arch which is having ectoderm on both sides here. And obviously in between we have this core of mesoderm. The pharyngeal arches are basically thickening of mesoderm only, so they are core of mesoderm we have in between. That's this yellow highlighter I'm using, it is for the mesoderm. Right, so we have everything with us. We have ectoderm, we have endoderm, and we have mesoderm also, and we have to see the fate of all. Some technical word that you should know. Between every pharyngeal arch, you will see that ectoderm and endoderm, they will come very, very close to each other. They come so very, very close. Actually, this is a schematic diagram, but you will see these two layers will be very, very close to each other, and with a minimal mesoderm in between. Mesoderm hoga, but the minimum mesoderm in between, and that is called as the pharyngeal membrane. See, guys, it is pharyngeal membrane. It is not buccopharyngeal membrane. Don't confuse it with that. Buccopharyngeal membrane was made up of ectoderm and endoderm. That was a different thing altogether. That was stomatodeum, opening of mouth. Right? This is pharyngeal membrane. It is present between every pharyngeal arch here, where the ectoderm and endoderm